Great. So I would like to introduce Dr. Zachary Marcum. Dr. Marcum is an assistant professor in the School of Pharmacy and director for research with the Pline Center for Geriatric Pharmacy Research, Education, and Outreach. He conducts clinical research in the areas of pharmacoepidemiology and health services, interventions to improve medication use in older adults. And we're just really pleased to have him coming and talking to you today about rational prescribing in Alzheimer's disease and related dementias. So take it away, Dr. Marcum. You're muted.
There we go. Thank you, Barb. I really appreciate the introduction and the invitation to present today. So for the purposes of my talk today, I'm going to be abbreviating Alzheimer's disease and related dementias as ADRD. So you'll see that throughout. And I also just wanted to point out that I've included my email address. If you have any questions after today's session, please feel free to email me. So I have no potential conflicts of interest for the content of this presentation today. And I thought it would be nice to have a little crowd participation. So I've included just a few poll everywhere questions for today's session. So this single link here, pollev.com/MARCUM, that will take you to the website. And when the relevant slide pops up, the question will pop up. So let's go ahead and practice that now. You can do it on a smartphone or a computer if you have access to those. And the website will prompt you to enter your first name, and then that's all you need to enter. And because I know we have folks logging in from a bunch of different areas, I thought it'd be interesting just to drop a pin on your location today. All right, so we have a lot of Pacific Northwest, somebody on the East Coast, Middle, Alaska. Great. Got broad representation of North America, which is great. All right, and now we all know that the poll everywhere is working. So perfect. So this will go away when I move to the next slide. But like I said, with the next question, the question will automatically pop up. So the objectives for today's session are to first be able to identify high-risk medications in older adults with ADRD. Second, to describe strategies to reduce medication-related harm in older adults with ADRD. And finally, to be able to suggest resources to colleagues, patients, and caregivers for safe medication use in older adults with ADRD. We'll cover additional material, but these are the primary objectives. So to provide context for today's session as part of this entire series, I wanted to briefly review, like Barb just did, the 4 M's framework, one of which is medication. And in this framework, the overall goal is to use age-friendly medications that do not interfere with what matters, mentation, or mobility. So keep this framework in mind during today's session, and we'll revisit it a couple of times. So the title of this session is Rational Prescribing in ADRD. So that begs the question, what is rational prescribing? Well, there's not a single definition, and if you ask 10 different people, you'd likely get 10 different responses. But for the purposes of our time together today, I wanted to share a couple operational definitions that I think are helpful. So first, this definition from Maxwell in 2016 states that it is a logical approach that includes making a diagnosis, estimating prognosis, establishing goals of therapy, selecting the most appropriate treatment, and then monitoring the effects of that treatment. So obviously there are a lot of components wrapped up in that definition, all of which are key when making prescribing decisions. Another more simplified way that people refer to rational prescribing is as appropriate prescribing, but you can see that that's not as comprehensive, but you'll see and hear people refer to it in that way. And there are many other definitions that one could give. So taking a big step back and thinking about how you could measure the quality of prescribing, I like to think about these 3 buckets, which are basically when the quality would be compromised. So it's kind of the opposite of high quality, could be low quality. And these are 3 categories where you might encounter low quality medication use. So there's overuse or unnecessary use, which is simply when there are medications there are more medications than are clinically indicated. The second is inappropriate use, which is defined as medication use in which the risk outweighs the benefit. And finally, underuse, which is when an older adult has a condition for which recommended medication is not being prescribed. And for the purposes of today's session, we'll focus on numbers 1 and 2. Another key component to today's session is ADRD. So let's think about what is unique about prescribing for older adults with ADRD. And I've listed a few on the slide to get us going. So because ADRD increases with age, on average, people with ADRD have accumulated a variety of other health conditions, leading to the presence of multiple chronic conditions, which makes it complex and challenging to prescribe without causing drug interactions or adverse effects. In addition, older adults with ADRD often have challenges with the actual management of medication taking, such as filling a pill box, picking up prescriptions from the pharmacy, and maintaining an up-to-date medication list. In addition, goals of care might change over time from the time that the medication was started, for example, moving from more of a curative approach to more of a symptom management, at which point the medication might no longer be necessary. And there are many other reasons. And so I'd like to ask you, just in a free text response, what else do you think is unique about prescribing for older adults with ADRD? All right, here we go. Changes in the blood-brain barrier and receptor sensitivity in the brain, that's great. Absence or presence of a caregiver, that's an excellent one. Very unique to this condition. Ineffective meds, yep. Caregiver involvement, another good one. They don't remember to take the meds consistently, so the doses get mixed up a lot. Yeah, so that kind of independent activity of daily living. Subjective information may be hard to rely on. Dexterity, social aspect, yep, delusions, paranoia, so some of the behavioral disturbances. Yep, lack of direct support in the home, ability to open the packaging, drug reactions. Yep, these are excellent. Compliance, weight changes. Yep, and if we're giving medications that can cause weight loss, that makes it even more complicated. High risk of fall meds, great. So we're going to talk about that a little bit. Need a Mediset, take multiple meds. Yep, so it's very cumbersome to manage. All right, so I'm hearing some themes of pharmacokinetic, dynamic changes with aging, some management challenges, the role of the caregiver. So thank you. These are all really, really good responses. Finances, yep. All right. So let's focus in a bit on inappropriate medication use in older adults with ADRD, which again, we define as medications in which the risk outweighs the benefit. And this is on average. So this of course does not apply to every patient, but just on an average kind of population level, it's where the risk outweighs the benefit. And one of the most commonly used references for identifying potentially inappropriate medication use in older adults is the American Geriatric Society Beers Criteria, which are named after a geriatrician, Mark Beers, and they're updated every few years. And the most recent version was published in 2019. So we'll probably have a new version in 2022. There are many components to the Beers Criteria, but the two main components include the main list of drugs that should generally be avoided in all older adults, which in the publication is Table 2. And that's probably what you're most commonly familiar with if you've heard of the Beers Criteria. And then there's also a component of drug disease interactions, which are drugs that should generally be avoided in older adults with certain conditions. And that's Table 3. So one example outside of ADRD is in an older adult with heart failure, for example, trying to avoid NSAIDs because they can cause fluid accumulation and exacerbate heart failure symptoms. For the purposes of today's session, we're going to focus on the drug-disease interactions with dementia or cognitive impairment, which include anticholinergics, benzodiazepines, the Z drugs for insomnia, and antipsychotics. So you might be asking yourself, why are these drugs recommended to be avoided in older adults with ADRD? And let's revisit the 4Ms framework and first focus in on mobility. So one of the main threats to independence and mobility in older adults is the risk of falling and the related injuries that could result. We know from decades of research that falling is a common issue in older adults, with the CDC estimating that 1 in 4 community dwelling older adults falls each year. And these rates are higher in older adults who live in long-term care settings, for example, upwards of half. We know that a smaller but sizable proportion of falls will lead to injuries or death. And with the aging of the US population, the overall number, the absolute number of falls and fall injuries is estimated to increase, as you can see in this figure here, in the coming years. In addition, we know from years of observational research that all of these medications previously mentioned in the Beers Criteria drug-disease interaction that we just covered, they increase the risk of falling in older adults, and especially those with ADRD. Just as one example of a recent paper that I was involved with that shows this, this was a paper that was led by Laura Hart, where she examined the association between CNS active medication use, which we defined as anticholinergics, antidepressants, antipsychotics, benzos, sedative hypnotics, opioids, and skeletal muscle relaxants. So she looked at the association between all of those and fall-related injury in a community dwelling sample of older adults with dementia who were matched with older adults without dementia. And we looked at medication use as current, recent, past, or no use, and no use was the reference group. So after controlling for a variety of potential confounding variables, we found that current use of CNS active meds were significantly associated with fall-related injury in these older adults with dementia compared to those without. So this is just one example of the type of evidence that is used to populate the criteria like the Beers criteria. And now coming back to the 4Ms framework, let's focus in on mentation, which of course is a major consideration in the setting of ADRD and in this entire series. And so for the sake of time today, we're going to focus on anticholinergics and benzodiazepines. So let's start with anticholinergics and cognition. So we first need to revisit some pharmacology and talk about acetylcholine, which is a neurotransmitter released by nerve cells, and it sends signals to other cells. And in this way, it acts kind of like a mail delivery person. The main functions of acetylcholine in the central nervous system include cognition, concentration, and memory. So when somebody is taking a medication that's anticholinergic, the drug binds to acetylcholine receptors, blocking its activity. And this is often done for the intended therapeutic effect that can be generated, but it can cause side effects such as impaired cognition and concentration and memory. And you're probably thinking about, well, which drugs are considered anticholinergic? There are many. That's kind of the high level message. There are dozens and dozens, and drugs vary in their anticholinergic activity. So I think it's most helpful to know and be aware of those that are considered strong anticholinergic drugs. And thankfully, the Beers criteria have made it easy for us by compiling a table of such drugs, which is table 7 in the Beers criteria publication. And it's here on this slide. So in looking at this list, you can see drugs like diphenhydramine or Benadryl, oxybutynin, and cyclobenzaprine, just as a few examples. Many of these drugs are older drugs that are not used as much, but there still are several strong anticholinergic drugs that we see used quite commonly in older adults. And so on the topic of anticholinergics and mentation, I think it's important to kind of understand where the recommendations come from. So I wanted to highlight just a couple seminal articles, and this one was published in 2015. It looked at the association between cumulative use of strong anticholinergic drugs and new onset of dementia in the ACT study, which is here in Seattle. And this study was led by Shelley Gray here at the University of Washington. And in this study, participants are free of dementia at study entry, and then they're followed up every 2 years since 1994 and 1996. And this study is housed at Kaiser Permanente, Washington. So we have access to computerized pharmacy refill data that were used to calculate cumulative anticholinergic use. And they looked over a 10-year period of time, and then they used a standardized diagnostic assessment to say whether or not somebody had dementia. And the punchline here is that they found that the most common anticholinergic classes used were tricyclic antidepressants, or TCAs, first-generation antihistamines, things like diphenhydramine, and bladder antimuscarinics, and that cumulative anticholinergic use was associated with a significantly increased risk of dementia. And that TSDD there, that indicates kind of a cumulative dose or cumulative burden. And you can translate that into daily use of a strong anticholinergic drug for more than 3 years. So for example, say somebody was taking olanzapine 2.5 milligrams for at least 3 years. That's what that translates into. And then a few years later, this study from the UK, they used their clinical practice research data link and selected patients with a new diagnosis of dementia, and then compared their prescription of anticholinergic drugs before diagnosis of dementia with that of a matched control group without dementia. And their findings were consistent with the previous Gray study, suggesting an increased risk from anticholinergic drugs and dementia. And this ACB equals 3, that's basically a way to indicate that they were looking at strong anticholinergic drugs. And in this study, because the UK has really longitudinal data, they were able to go back quite long prior to the dementia diagnosis, which is a great strength of their data. So that's what the evidence says. Those are two kind of exemplary studies. And what do patients think about this topic? So in this study, we did a survey of Kaiser Permanente Washington members. You can see here the sample size, which was largely white women between the ages of 51 and 70. And one of the take homes here is that only 1 out of 3 respondents reported that OTC sleep aids like Benadryl were very or somewhat harmful to brain health, with 2 out of 3 reporting that they don't know. So this is a big opportunity for patient and caregiver education. So to summarize the anticholinergic and dementia risk topic, the consensus is that they increase the risk of dementia, and it's thought to be in a cumulative and dose-dependent manner. We also know that anticholinergic drugs can worsen cognition in older adults with ADRD, so they should definitely be avoided if possible. And we also know that patients and caregivers are often unaware of these risks. So we need clear and consistent education using patient-friendly language and on an ongoing basis. I don't think we can take this risk for granted that patients might know about it. We need to be reminding them. So now let's talk about benzodiazepines. Some of the most commonly prescribed ones are listed here on the slide. And for the purposes of pharmacodynamic activity, I think we can also lump in the Z drugs for insomnia with benzos because they essentially work the same way. Benzos act on the central nervous system by enhancing the effect of the neurotransmitter GABA. However, they can lead to delayed recall and memory impairment, as well as impairments in a variety of other cognitive domains. Benzodiazepines are also challenging to use because they can lead to significant withdrawal symptoms, which are illustrated on this slide. So if an older adult is taking a benzo as needed, for example, they could experience some of these effects even in that short-term use. And so once somebody has started on one of these drugs, it makes it a little bit difficult to stop, especially in older adults who have been taking them for a long period of time and especially at higher doses. And we'll talk a little bit in the second objective about some evidence showing that we can actually stop these, but it takes some patience and some care. When we look at the evidence of benzo use and risk of dementia, it is not as clear as that with anticholinergics. However, we do know that benzodiazepines can worsen short-term cognition in older adults with ADRD. And so by all means, we should be avoiding these if possible. These are really not good drugs to be using in our older adults with ADRD. So that was inappropriate use, and we focused on anticholinergics and benzos. And so now we're going to shift from talking about potentially inappropriate medication use to overuse or unnecessary use in older adults. In general, the best approach for determining whether an older adult has any overuse or unnecessary use of medications is to start by listing their medical conditions and then listing their medication list next to that, and ask yourself whether or not there are medications they're using for which there's no clear medical condition. And if so, then this should be looked into further because it could be a scenario in which there is overuse. So just from your experience, can you think of any examples or ideas of medications or classes that you think could be overused in older adults with ADRD? And this is just like the prior question. You can just enter free text. Giadan Serquo. Sulfonylureas. Antiemetics. Great. So maybe something that was needed at the time and it's no longer relevant. Antipsychotics, that's a great example. Sleeping medications, yep. Could have been a temporary bout with insomnia that's no longer relevant. Haloperidol, opioids, yep. Zyprexa, antipsychotic, antipsychotics. All right. Gabapentin, yeah, that's a big one and one that we're seeing more and more of. Steroids, yep. So could have been for a short-term inflammatory condition and it's no longer needed. PPIs, that's a great one. Yep, we see a lot of PPIs continued post-hospitalization. Gabapentin. Antibiotics, yep. So really, when you think about the definition, any medication could be considered overuse, right? As long as the patient doesn't have a condition. But like you all have illustrated here, there are some that tend to pop up more often than others, and you all have done an excellent job summarizing those. So one category that I want to focus on today, and one that was not mentioned, and oftentimes I think we overlook them because we think that they're kind of harmless, but it's supplements that are marketed to be good for the brain, whether in older adults who don't have dementia, but they're trying to prevent dementia, or in older adults with dementia. So I'm sure if you're like me, you've been sitting, watching TV in the evening, and up on the TV pops a commercial, sometimes even multiple commercials in the same segment for Prevagen. And with these bold claims in clinical trials, it's been shown to improve short-term memory. It's a breakthrough product, and the secret ingredient is originally discovered in jellyfish. So, how cool. Why would you not want this? Sounds very exciting. There are other products. For example, this one, Neriva, is a newer product that I've seen. And in looking at the product label, it appears to mostly be caffeine. So we know that over time, these products are increasing in their use. This is just a Google search term trend showing over time, more and more people are searching for Prevagen. And because this is a highly unregulated field of medicine and pharmacy, the internet is just ripe with a lot of misinformation. And so this is just one example I wanted to share with you. So you look at this website here, and it has a very official looking title, Alzheimer's Research and Prevention Foundation. And then it gets into making some pretty bold claims, recommending that people should be sure to take their vitamins and memory-specific nutrients. And it even suggests optimal dosages from an array of vitamins and nutrients. And so just to kind of get to the punchline, this is definitely overstating what we know from the literature, which we'll get to in just a minute. But I think a big part of patient education around this topic is helping people navigate the internet and helping them find some reputable sources for this type of information. And we'll get to that in the third section today. So this was a systematic review from a couple years ago in which the authors summarized the evidence for OTC supplement interventions to prevent cognitive decline, MCI, and Alzheimer's disease. And they found 38 trials that had low to medium risk of bias that looked at a variety of different supplements. So they found studies looking at omega-3 fatty acids, soy, ginkgo biloba, B vitamins, vitamin D plus calcium, vitamin C, beta carotene, et cetera. So they summarized all of the evidence, and unfortunately, the evidence is insufficient to recommend any OTC supplement for cognitive protection in adults with normal cognition or MCI. Now, the caveat with all of this topic is that there are certain people that have vitamin and nutrient deficiencies, and those people, of course, would be indicated to receive replacement or supplement. But this is just for your average patient that does not have a deficiency or need supplementation. The evidence is simply not there when it comes to preventing cognitive decline. This was a more recent report from the Global Council on Brain Health, which is an independent collaborative of scientists, health professionals, and scholars from around the world who work on different areas of brain health related to human cognition. And they're supported by AARP, which you're probably familiar with, and kind of the UK equivalent called AGE-UK. So they met in Washington, DC, and kind of came up with this report, which I think is really useful for a broad range of audiences. So just to kind of define what it is that we're talking about when we say dietary supplements, these are products that are taken by mouth that contain a dietary ingredient. So it could be anything from vitamins to minerals, botanicals, enzymes, and they come in basically every possible dosage form you could imagine. I know you have the slides, so this is not much of a quiz, but I think this number is quite shocking. How many dietary supplement products are sold in the US? As of 2018, it was approximately 85,000. And the reason for this is that there's a lot of money to be made. So the retail sales were greater than $40 billion in the US alone. An important context for this discussion is around manufacturing and approval. So globally, manufacturers are generally prohibited from selling unsafe ingredients, but they're largely unregulated when it comes to evaluating the effectiveness before they're permitted to be sold. And this is in contrast to prescription drugs, which have to prove their efficacy prior to, say, FDA approval. So in other words, the FDA does not determine whether dietary supplements are both safe and effective. And the AARP also did a survey as part of this, this brain report, and they asked older adults for their views on this topic. So among adults aged 50 and above, 81% believed that supplements were at least somewhat important for overall health, and about 3/4 were currently taking a dietary supplement at least 3 times a week. And specifically for what we're talking about today, memory supplements, this is a growing portion of the overall market. And you can see here that sales are going up, and more than 1/4 of Americans aged 50 and above say that they're regularly taking a supplement for their brain health. And then when you drill down a little bit farther, 11% say that they're currently taking a supplement for the stated purpose of delaying the onset of dementia, which we just talked about. There's no evidence to support that. And 8% report that they're currently taking a supplement to reverse dementia. Of course, we don't have evidence to support that. And even our prescription drugs for the treatment are not reversing. They're not disease modifying. If anything, they're slightly changing the trajectory, if at all. So there's a lot of misunderstanding here in this space as well that I think is prime for outreach and education. And just to come down a little bit harder on Prevagen, because I think the media blitz is quite intense. So the jellyfish product here is listed. apocorin. It's isolated from this specific jellyfish, and the main clinical trial used for claims of benefit did not have a control arm, which is not how we generate the most robust evidence. And then a second clinical trial failed to show improvement. And pharmacologically, this protein is likely broken down in the gut before reaching the brain. So, there's a lot of legal work that's being done to try to kind of come back on them for overstating their claims. But I think for your purposes, it's important to know that there's no evidence to support this product. And most older adults, who might be interested in using this would do better if they just save their money, because these products are also quite expensive. So just to summarize the consensus statements from this GCBH report, they say that for most people, the best way to get nutrients for your brain health is from a healthy diet. And in fact, the Mediterranean-based diet is the one that has the most evidence to support its effect on brain health. So they don't endorse any specific ingredient or product unless, like I mentioned before, the healthcare provider has diagnosed them with a specific nutrient deficiency. The topic of fatty fish and omega-3s is a little bit more nuanced, where they say that consumption of fatty fish could benefit cognitive function, but it's not proven. So, consuming through diet could be helpful, but there's not sufficient evidence to recommend taking a fish oil supplement. So again, the best way is probably through diet. They point out that supplement manufacturers and distributors often make vague or exaggerated claims. So we should approach these products with skepticism. And also the quality of ingredients in supplements can vary widely. And there's some evidence that sometimes, products that aren't necessarily on the label end up in the bottle. And so you want to pick a manufacturer that is trustworthy and reliable. So again, we should be exercising a lot of skepticism with these products. So that's the first section. And so we'll now shift gears and talk about some of the strategies that we can employ to reduce medication-related harm. So before we can do anything, we need to be confident that we are working with an updated medication list. And this starts with a quality medication reconciliation, or MedRec. And the best way to do this is to have the patient and or caregiver bring their actual pill bottles and a medication list, which we typically call a brown bag method. Or if you have the opportunity to do a home visit, that is even better, because you can see how they store their medications and see if they have any issues or need advice on how to get rid of old or expired medications. To do a MedRec, you will likely need to use a combination of information sources, including asking the patient, looking in the electronic health record, and also just a plug for pharmacy. Know that you can always call their community pharmacy to ask about anything. So if you're curious whether or not they've been getting something filled, you can call the community pharmacy and they'll be happy to help you. I think it's important to recognize that conducting a quality MedRec takes a lot of time. So really, the pharmacist is, I think, ideally situated to help with this. So if you have access to a pharmacist, this is a great activity for them to help with. And the best way, this sounds kind of obvious, but just a reminder, the best way to reduce high-risk meds is to not start them in the first place. So oftentimes we're inheriting patients who come to us on these drugs. But again, just a reminder, the best way to reduce them is to not start them. But I acknowledge that's not always possible. And the risk benefit changes as we age. So a drug that was started years ago could have been entirely appropriate, but over time with aging, the new onset of ADRD, it's now considered inappropriate. And it's time for us to consider something that we call deprescribing. Because a lot of what we've talked about has led to this point in which we've identified a medication or medications that we want to stop or reduce the dose of. So again, enter the conversation deprescribing, which is kind of a mouthful here. And it's a little bit related to that earlier description of rational prescribing, right? So deprescribing is just part of quality prescribing. So these authors here define it as the systematic process of identifying and discontinuing or reducing the dose of meds in instances in which the existing or potential harms outweigh existing or potential benefits. And these decisions should all be aligned with the patient's goals, current function, life expectancy, values, and preferences. So this is a pretty complicated process if you were to take into account all of that. I'm jumping the gun here a little bit in terms of resources. I know that's in the third section, but just because we're talking about deprescribing, I wanted to point out that there's a nice succinct summary of deprescribing that's pretty up to date on the drug resource Up to Date. So if you have access to that and you're interested in learning more kind of about this space and where the evidence is at, I recommend having a look at that Up to Date chapter.
Zach, do you want to take any questions right now? There's a couple in the Q&A box. I can read them off to you.
Yeah, go ahead.
So one of them is, why doesn't the FDA regulate supplements more? Is this something that you see changing moving forward, given the growth and profitability in this area?
Great question. So this comes down to a law that was passed that is related to supplements and vitamins that basically hasn't been challenged or hasn't been changed for many, many years. So there's a law that allows this marketplace to operate in the way that it does. And there are, of course, a lot of laws that dictate what the FDA must do. So this was a decision basically by policymakers a long time ago that has not been changed. Do I see it changing? I haven't heard any rumblings of a strong move to do so. Again, I think there's a lot of money in this space. Unfortunately, that drives a lot of the decisions. I would love it if it were more regulated, because it's a very confusing and feels quite misleading. You know, just when you're watching one of these commercials, it just feels very misleading.
And do you see that similarly with all of the ads about CoQ10?
Yes. So, yep, another great example of the ads about CoQ10 and whether or not it should be taken, you know, with your statin, without. This all kind of falls under the umbrella of direct-to-consumer advertising, which the United States is unique in that way for both prescription and non-prescription products. So that's not a global phenomenon. It's something that's very specific to the US. But there is a specific agency at the FDA that's responsible for monitoring those commercials, for example, for prescription products. And if they find that the manufacturer is overstating claims, they're not very well staffed and they don't have a lot of regulatory power to do much about it, but they will come down on the manufacturer and make them, you know, air a corrected version of their ad, for example. But again, this is all focused, that regulatory power is all focused on prescription products. So the CoQ10s, the Prevagens, they have a much lower bar.
And then there was another question related to what might be the HIPAA regulations about contacting pharmacists?
Yeah, good question. So the HIPAA considerations. So as long as you're calling about one of your patients and you know that that's their pharmacy, the patient has told you where they get their prescriptions filled, there's no special considerations that need to be made in terms of HIPAA. Pharmacists will understand what's happening, and the term medrec is used a lot now. So if you tell them I'm doing a medrec for so-and-so, they fully understand and you're complying with the HIPAA regulations as part of regular care.
Thanks.
Great questions. Yeah, feel free to interrupt at any time with additional questions as we go. So back to deprescribing. So, you know, we talked about the definition, and in that definition, it says that, you know, you could do it when the harms outweigh the benefit. So some examples of when there are clear harms could be a potential adverse effect. So say an older adult with Alzheimer's disease who's taking an opioid and has a hip fracture, right? They fall and fracture. So that could be an opportunity to consider deprescribing or lowering the dose. in that moment. If there's uncertain benefits, so as we age and we accumulate chronic conditions, the evidence is less clear on how we should be managed. So in situations of multimorbidity, that could be a time to consider deprescribing, especially late at life in hospice settings. You know, it's probably very safe to assume that you don't need to be taking, you know, certain vitamins and supplements at that point, let alone certain things for like diabetes, right? You're not really worried about your A1C. And on a larger scale, if there are changes in goals of care, that's a good time to kind of look at the meds and think about whether or not deprescribing could take place. And then finally, there's this kind of pharmaceutical trivia term called prescribing cascade. And if you're able to detect a prescribing cascade, that's always a good time to think about deprescribing. So a prescribing cascade is where there's one drug that then causes a side effect, which is misinterpreted as a new medical condition that's then treated with drug 2, which we never want to do. We never want to treat a side effect with a new drug. So these sometimes are hard to detect, but I've listed a couple examples here for you to think about. And so I encourage you to think about finding these in your practice. So for example, if a patient has pain, they take an NSAID, their blood pressure worsens, then another antihypertensive is added. That could be an example of a prescribing cascade. So rather than adding that other antihypertensive, you could consider a different analgesic rather than the NSAID. So how do we deprescribe? Well, there's no one right way, but I think it's helpful to just kind of think through some of these concepts. So we mentioned getting all the drugs that the patient's currently taking and the reasons for each one. So that's the good quality med rec. Then you want to consider the overall risk of drug-induced harm in determining just how intense you want to be with deprescribing. And in the setting of ADRD, I think we really want to be focused in on those CNS active medications. So the drugs we've talked about, anticholinergics, benzodiazepines, the Z drugs, antipsychotics, opioids. And then just systematically go through each drug quickly and think about whether it's eligible for deprescribing. Then you probably can't do them all in the same visit. So you want to have some sort of priority. So maybe you do one this visit, you know, with phone follow-up, see how it's going, and then tackle some other lower priorities at subsequent visits. And then you implement and monitor your deprescribing. I think this article here is a nice summary of how you can think about becoming a deprescriber, and we'll go through each of these 3 components. So the first is to use a model or a framework, which is basically just kind of a way of thinking about it. So, you know, you could think about it from the angle of goals of care, time to benefit. You know, statins need to be taken for at least, you know, 2 to 5 years to achieve clinical benefit. So if the patient's life expectancy is less than that, then that could be a good drug for deprescribing. So just kind of become familiar with some sort of model or framework to even begin to approach deprescribing. Own the list. So this again is getting back to that medication reconciliation, prioritizing. And then I think the point here is just pick something and start with it. So don't overthink it. There are an accumulating number of tools and algorithms that are available that I'll show you in just a minute. So pick, you know, a medication class, a specific medication that you want to learn more about and how to deprescribe it, and start there. So I think that's kind of going from a broad sense of using a framework down to a specific strategy. Like I mentioned, there are a wide variety of tools that are available. We talked about the Beers Criteria, which are kind of explicit lists of inappropriate medications. There are also different deprescribing algorithms that exist. So around the world, there are groups that are working on this topic of deprescribing. So we have folks in Canada who are really leading the way, folks in Australia, and folks in Europe, as well as here in the United States. Like I mentioned, in Canada, they have a deprescribing network called CADEN, C-A-D-E-N, and their website is really easy to remember. It's deprescribing.org. And I would encourage you to check out their website because they've developed a lot of really elegant resources for patients and healthcare providers, including specific deprescribing algorithms for different medication classes, pamphlets for patients, links, case reports, and publications if you're interested in the evidence behind it. Just to show you an example of what I mean by their deprescribing algorithms, and one of the comments that was left before was sulfonylureas as possibly drugs that are overused. So this is an algorithm that could be used in that scenario. So you see here, kind of, it's very clear from a design standpoint. It's easy to follow, and it gives you some monitoring tips. And you can use it freely. They're not charging for these. And they just continue to generate more and more of these algorithms. So chances are they either have something that you could use or they're working on it. Now, this all sounds great and exciting. And of course, there are challenges. So deprescribing is hard. Oftentimes, we have all this evidence for how to start a drug, right? We have the trial evidence, and then we have clinical practice about starting drugs. But historically, there's very little evidence on just how to stop a drug. And so there's just a lot to learn, and that's the lack of evidence here. Sometimes there is confusion over whose job it is to deprescribe, and that's something to sort out with your individual team, figure out kind of who's in charge of thinking about deprescribing, and then who's going to implement it and manage it. For certain medication classes like benzodiazepines, we worry about the risk of adverse withdrawal events, which can be quite serious if they're not monitored carefully. Sometimes patients have very strong psychological connections with the medications. They might think, oh, you're stopping this, are you giving up on me? So you have to be kind of ginger with your communication around the reason why, and try to align it with their goals of care to get buy-in from the patient and to make them understand that you're not giving up on them. In fact, you're trying to help them achieve their goals. So one class that I think we oftentimes think is really, really hard to deprescribe is benzodiazepines. And we've talked about this class in a few different ways today. So I just wanted to highlight this article from the group in Canada that they published in 2014, which was called their Empower study. And in this study, they enrolled patients who were recruited from 30 different community pharmacies. And the punchline here is that they were successful. So you can see here, 27% stopped the benzodiazepine in the intervention group compared to 5% in the control group. And this was a direct to patient advertising sort of approach. So patients on benzos were targeted with this pamphlet here that showed which one they were on, and included a bunch of different patient-friendly education, and then had a specific tapering program for that patient. And it turned out that it was quite successful. This group has gone on to do another study called Deprescribe, where they've kind of triangulated with the physician or the prescriber and the pharmacist and the patient, which is also shown to be successful. So even with the hardest of drugs that we think, benzodiazepines, we can have success if it's done appropriately. Another question you might be asking is, well, I just don't think my patients are interested in this. I don't get that sense. So we have some evidence that was published recently from this questionnaire that was developed called the Patient Attitudes Toward Deprescribing. And just the high level point here is this top line: if my doctor said it was possible, I'd be willing to stop one or more of my regular medicines. You can see here in the dark teal and the light teal are strongly agree or agree. So the vast majority of these are older adults, Medicare age, say that they would be willing to stop. And I think the operative part here is if the healthcare provider said it was possible. So we really do have a lot of sway and power in starting this conversation. I've mentioned this before, but I just wanted to reiterate that communication is key when it comes to deprescribing. So I think a couple points that are highlighted in this article are worth revisiting. So it's important to take advantage of opportune moments. So for example, if a patient has a fall and has to go to the hospital, that could be an opportune moment to kind of revisit the medication list, to contextualize the patient's attitudes, goals, and preferences. So you say, I hear that you don't want to spend so much time in your day organizing your medications and taking medications. To help you achieve that, how about we get rid of, these supplements or these topical products that you're not really using much anymore? So that's a way to kind of align yourself and contextualize with the patient's stated goals. This is not something that can be done in a single visit, and it certainly takes time. So I think it's important to prime the pump, to kind of plant the seed, maybe at one visit, and then revisit at the subsequent visit. And it's important to understand that stopping omeprazole, a PPI, is different than stopping oxycodone. The time and attention that's going to be needed to deprescribe those two drugs is going to be pretty different. And so it's important to just recognize that not all drugs are the same when it comes to deprescribing. So what is the future of deprescribing? Well, the US has a new deprescribing research network that was launched a couple years ago. So that's really exciting. We're now kind of on the global deprescribing stage. It's funded by the National Institute on Aging. So there's a lot of research activity that's going on to figure out the best way to do this and how to best engage patients in a safe and effective manner. There are also clinical trials that are ongoing for the first time in a long time that are testing different strategies for deprescribing. And this is just one example of the R2D2 trial, which is reducing risk of dementia through deprescribing. And in this cluster RCT, they're going to test whether the adverse cognitive effects of anticholinergic meds are reversible by implementing a pharmacist-based deprescribing intervention for older adults within primary care practices. This is taking place in Indiana University. And the target population is primary care older adults with subjective cognitive decline or who make at least one error on a cognitive screening test but do not have dementia. And they're currently using a strong anticholinergic medication. So for example, that table 7 that we talked about earlier. And the intervention and follow-up data collection are going to occur over 24 months in order to test the long-term impact of this intervention. And there, you can see here their primary outcome is cognition with secondary outcomes of safety. So that's really exciting to see. I know of at least one other intervention that's reducing anticholinergics, and I'm sure there are going to be others as well. So this is a kind of a rapidly growing space, which is exciting to see. So to summarize, some of our take-home points from this section, our overall goal is to minimize exposure to CNS active medications in older adults with ADRD to the greatest extent possible. Among those who we can't, and those who are receiving CNS active meds, we should, on a routine basis, be considering a dose reduction or discontinuation if appropriate. And then stay tuned for trial data on deprescribing anticholinergics as well as other medications that are used by older adults, both those with and without ADRD. And I think I can't emphasize this enough. We should always be thinking about how can we best educate our patients and caregivers on these medication risks, for which we have very clear evidence of harm if taken, over a certain period of time. So I think that's something that we'll always need to be working on. So I'll stop there and just see if there are any questions before we go into the third section.
We did have a question about, again, about supplements. Wondering if there's a reliable go-to place that informs people of the efficacy or lack of efficacy of these supplements. It would be nice to be able to pass this information on to older adults, for example. Or
yeah,
maybe there's an informational flyer or something.
Yeah, that's a great question. I think I'm going to get to a part of that answer in this third section, which is an online resource specifically related to their effect, brain supplements. But if you have access to a library, and I know not everybody does, like a health library, the National Comprehensive Medicines database is the best source for looking up supplements and minerals and things like that. The Natural Medicines Comprehensive Database. So if you have access, again, to a health library, and your university or institution subscribes to it, that's the best place to go. If not, I'm going to point out something that's available online in this next section.
Thanks much. We just had someone else who chatted in that there's a great book called Vitamania that explains the supplements issues.
Ah, great. I'll have to read that. Yeah, I read a good book this past year on the generic prescription drug industry, which was eye-opening and fascinating. So there are a lot of really good books out there in the pharmaceutical space. All right, so now rounding the final turn here, we're going to talk about some resources that you could use with colleagues, patients, and caregivers for safe medication use in older adults with ADRD. And I'm just curious to get us started here. This is our last poll everywhere. What resources do you use or have you heard of related to medication management in older adults with ADRD? Pharmacist, oh, I'd love to hear it. Up to date, great. Automated pill dispenser. GRS, okay. Beers Criteria, yep, tried and true. Up to date. Pharmacy. All right, the webinar's here and today. Hippocrates, yep. Home health nurse for med management. Yeah, home health nurses are priceless. Up to date, Beers Criteria. Yeah, so we have a lot of really good resources. Geriatrics at your fingertips. Yep, that's a great resource that comes with a membership to the American Geriatric Society. Gerontology psychologist, pharmacist letter. Oh yeah, I love the pharmacist letter. It's very succinctly written. Physiatrist, okay. Some textbooks. Great. So I think hopefully I'll share with you some resources that haven't been mentioned. Somebody did mention the Beers Criteria and you just knew I was going to talk about it. So I just wanted to point out, when we say the Beers Criteria, typically what people assume is that it's a manuscript, it's an article, a PDF you would download. Well, the American Geriatric Society has gone to great lengths to make it accessible in other forms as well. So if you're so inclined, there's a mobile app that you could download. There's also a pocket reference card that you could purchase or get with a membership for your practice. And this website here, healthandaging.org, has a lot of really good resources to help older adults understand what we mean when we say potentially inappropriate, because obviously that kind of depends on how you interpret that. So I would encourage you to go to healthandaging.org to find some patient facing materials. So for example, you can see here this tip sheet, 10 medications older adults should avoid or use with caution. And these are kind of written in the style and tone of like a Consumer Reports. This tip sheet here, avoiding over medication. Here's one on a diary for meds and supplements. Yeah, so I would encourage you to check out that website. This is an example of one of these tip sheets, the one on avoiding over medication and harmful drug reactions. I think it's very nicely designed, easy to digest, and something that you could print out on both sides on a single sheet. This is not something that the group mentioned, but the National Institute on Aging, which is one of the institutes of the National Institutes of Health, they have this center called the Alzheimer's and Related Dementias Education and Referral Center that was developed back in 1990, and it was created for use by a lot of different stakeholders, including health professionals, patients with AD, family members, and the public. And so there's a lot of really great resources that are available for free. And there's even a toll-free number if you prefer to just call them and ask them your specific question, or you can email them. And they have here, for example, this Alzheimer's caregiving, managing medicines for a person with Alzheimer's. So that's a great resource if that's something that you're looking for. Nobody mentioned this, but the Alzheimer's Association is another great resource. So you can see here, if you go to the Alzheimer's Association website, and then you click on the treatments subheader, you can go down and click on any of these topics. So for example, alternative treatments, treatments for sleep changes, questions for your doctor, etc., medications for memory. So the Alzheimer's Association is a tremendous place for resources for all things related to AD, but also for medications. And they also have a helpline. This is the resource that I referred to earlier when somebody asked about, well, how do you find out more about different vitamins and supplements? So this is called Cognitive Vitality. And their goal is to evaluate the available evidence on strategies to promote brain health and prevent dementia. It includes everything, including FDA-approved drugs, so prescription drugs, as well as herbal supplements and vitamins. And I think they do a really nice job of summarizing everything you'd want to know, because they have these three different categories. One is evidence. So what did the studies say? Potential benefit, and then safety concerns. And they have a rating system that I'll show you. So for example, this is the evidence system. So these 4 books they represent the highest level of evidence. So there's evidence from multiple RCTs, and then all the way down to no books is no human clinical studies have been conducted. And again, this is all specific to brain health, which is the topic for today and why I think this is a really useful resource. Then the next category is the potential benefit. So 4 brains here indicate that the research suggests clinically meaningful benefit for long-term brain health. And then down here to no brains. And then safety. So 4 of these shields here indicate very low risk, all the way down to 1 would indicate high risk. So this is so if you have a patient or a family member or a caregiver ask you about some random supplement or vitamin that you've never heard of, I would say check it out here first and see what they have summarized for you. And I like it because they include the last date that they've updated it, and then they summarize it here, on one specific screen. So it's nice to kind of see it all, and then you can click further to see, okay, well, where are they pulling their evidence from, for example. So this shows a prescription product, the ARBs, as well as an herbal supplement. And I just wanted to end on a couple additional resources related to COVID, because that's the context in which we're all living and working right now, in the context of pharmacy. So this is a video that I'm not going to show today, but you can watch it afterwards. It's a very short video, just a few minutes, on how older adults can navigate the pharmacy during COVID-19. And it's meant to be patient-facing, so please feel free to share it with your communities and your circles. I'll just say one of the take-homes here is that a lot of pharmacies now are delivering prescriptions for free, whereas they may not have before COVID. So that's just a service that I think you should be aware of and know about, and encourage your patients and loved ones and caregivers to pursue that if it's something that would be helpful. And then I know we're typically focused on primary care, but this is another resource that came out about COVID-19 focused on post-acute and long-term care and ways to optimize medication management during the pandemic. And this was developed in collaboration between the US Deprescribing Network and the University of Maryland School of Pharmacy. And you can see here, this is the summary, the bullets here, but basically, we want to try to minimize the number of administrations per day, get rid of any unnecessary products that the patient doesn't need. And so just trying to reduce the timing and the actual interaction between the person administering the meds and the patient is going to reduce exposure. But you can click on that link there to look at the full report. And this was developed back in April. So hard to believe, but coming up on 9 months now. So just keep that in mind as well. So we are now heading toward the end, and I just wanted to summarize some of the key takeaways from today. CNS active medications can negatively impact mobility, mentation, and what matters among older adults with ADRD. Deprescribing is a systematic approach to reduce the dose or discontinue meds for which the risk outweighs the benefit, or there's unclear benefits, or goals of care have changed. And we have access to a variety of resources to support safe medication use in older adults with ADRD. So I would challenge you all to commit to learning about one new resource and then tell a colleague about it so we can pay it forward. And with that, I'm happy to take some additional questions or comments.
Thanks so much, Dr. Marcum. I do have a couple of questions already. One is asking about the extent to which prescribers benefit from prescribing more medications.
So the question was about the extent to which prescribers benefit from prescribing more meds. So in the sense of like conflicts of interest and getting kickbacks from pharmaceutical industry?
That was my assumption, or yeah, if they tend to provide those meds out of their own house, I guess, out of their own facility.
I see, yeah. So in geriatric.
Sorry, it was clarified why they're so readily prescribed, you know, for those that are really readily prescribed.
I see. So I think I'll try, and if I don't quite answer the question, please feel free to clarify. But I think, first of all, the most common intervention in medicine is to prescribe something. So I think that's just kind of how we're all trained. And when we see a symptom or a new problem, our tendency, whether it's good or bad, is to do something about it. And oftentimes doing something about it is prescribing. But in geriatrics, you know, there are quality ratings that are put down upon geriatricians and prescribers to try to kind of use the less is more approach. So oftentimes prescribers will be dinged in their quality ratings if they're prescribing these Beers Criteria drugs or, you know, antipsychotics in long-term care. So there are disincentives for them to prescribe some of these drugs. So I think in geriatrics, oftentimes it's the opposite. That we're really trying to peel things away.
Question about whether or not you have done, let's see, where was that? Studies on natural remedies or supplements within your group?
Yeah, good question. So I haven't personally done any studies on, you know, kind of testing whether or not they work. I've done more of just kind of describing how often older adults use vitamins and supplements. So unfortunately, the resources that are available to do this type of research are much lower than for prescription drugs. So it's just a really hard space to navigate in terms of research. But from my experience, using data from something called HRSA, which is the Health and Retirement Survey, it's a nationally representative survey of older adults. We recently did some analyses and looked at, and nearly 80% of older adults were using some vitamin or supplement. So it's really high prevalence of use. But I personally have not done anything in terms of testing, you know, which ones are effective or not. But I think, you know, it's important to enter these conversations with patients with cultural awareness as well, because we can't just come in and say, you know, these don't work, we don't have evidence. That's going to turn a patient off. And so I think we need to be careful about how we raise these conversations with patients. And, you know, oftentimes it may not be doing any harm, but if it's a patient who has financial concerns and they're spending a lot of money on the products, then that might be a nice, you know, topic to bring up of, you know, hey, do you really need to be spending $60 a month on your Prevagen?
Okay, sorry, I'm multitasking here a little bit. Are there any placebo effects for the use of supplements?
Yeah, great question. So yes, I would say the placebo effect has been well documented, regardless of whether it's a prescription drug or a supplement. Just the act of taking something is therapeutic. So yes.
Do you think COVID will accelerate the number of people with dementia?
Ooh, good question. Well, COVID elevate the number of people with dementia. So will COVID? So the interesting thing about COVID is that people who get sick, get really sick and stay sick. You know, they're in the ICU for much longer than your average acute care issue. And so I think we're seeing higher rates of delirium, for example, and to the extent that that is related to kind of long-term cognitive impairment that could turn into dementia, that's one possible way that I think it could, but it's hard to know at this point.
What do you see as barriers for physicians to review and adjust medications lists? Can there be hesitancy for physicians to deprescribe if a medication was originally prescribed by another prescriber? Is time-limited visits a hindrance also?
Yes, you've beautifully outlined a couple of the main barriers. So there's what we call prescribing inertia, meaning kind of an I would rather not rock the boat sort of mentality, whether it's due to the fact that the patient's been on it for years and nothing is wrong, or someone else started it and I don't want to rock the boat. So yeah, that kind of gets at that question I mentioned of like, who's in charge of the medication list? And that's just really challenging. And so it takes a lot of communication across providers to kind of understand why we might be wanting to deprescribe and kind of who's in charge. So yes, there's the barriers that you mentioned are certainly two of the most common. The time as well, it takes time. And so, you know, if the patient comes in and has 3 other more acute issues, the deprescribing conversation is probably not going to happen unless it's related to one of the acute issues. So again, if you have access to a pharmacist or, you know, nursing or other providers, you know, beyond the physician, certainly lean on them. But this is a challenge just given the structure of our healthcare system and the way healthcare is reimbursed.
So Mary has said that she recently heard that trazodone should not be used in AD. She has used small dose 25 milligram trazodone for anxiety in AD and then have the caregiver do something like a walk around the room. Thoughts on that?
Yeah, so trazodone is a drug that I would be careful with, especially in an older adult with AD due to the CNS side effects. I think a couple of things you mentioned there, starting low, if you're going to use it, is good. And then closely monitoring is also good. But yeah, it certainly has the potential to cause some dizziness and drowsiness and a fall.
Okay, I do not see any other questions unless there are questions that people, oh, here's one. Oh, thank you. I'm saying thanks much for the talk. This is really informative. I've actually gotten several queries, Dr. Marcum, for people to be able to look this over again and refer it to other people. So
oh yeah,
that's helpful. A question about regarding advocacy. How can we help change policy to regulate the oversight of supplements to avert misinformation? Any thoughts on that?
Oh, I love the question. You know, I think a big thing is to work with your local representatives and let them know that this is an issue that you care about. Stay informed, raise awareness. Those are all things that I think an individual can do. If you have an opportunity to kind of get more involved through some sort of formal training related to health policy, that's a good way to go as well. So you can kind of learn how it works. I've not done that myself, but what I do is I just try to stay informed, spread the word, and yeah, just try to raise awareness.
And Caroline is asking if you're aware of any electronic health record features that assess for aging out alerts or that get triggered by diagnosis, age, or weight.
Could you say that first part again? I missed the first part.
Any electronic health record features, you know, like alerts that might come out as people get older, or they might be triggered by diagnosis or weight in relation to age?
Yes. Great question. Yeah, so I know of EHRs and institutions that have triggers for like Beers Criteria drugs. They'll pop up. And again, this is the way it works is it's oftentimes driven by the quality measures. So that the policy body decides what they're going to measure for high quality. Then the systems react and develop alerts and try to, meet those quality measures. So that's why it exists. And the ones that I'm aware of are related to these high risk meds that we talked about today. Sometimes if a group has a focus on falls, they'll have maybe fall relevant alerts as well.
So Linda mentions they've created their own CDSS alerts in their electronic health record, and which is ECW. I'm not sure what that is. And she said they've also created their own geriatric empanelment report to focus on the 4Ms, which is pretty cool.
That's really cool, yeah.
Okay. eClinical works. Most federally qualified health centers have that sort of cheap electronic medical records system. So this
Great.
is,
I love to hear it.
Yeah. All right. Well, thank you. This just has been a great presentation. We really appreciate it, Dr. Marcum. And I think everyone has a link to the evaluation form that I submitted earlier. We will see you next week. And thanks, Dr. Marcum.
Thank you all.